Hi guys, this is the third time I have tried to record this lecture, so I apologize if I get a little short at any points of this. Um, just a lot going on in my office currently, lots of knocking, lots of phone calls, so bear with me. Hopefully I don't have to record this for a fourth time. Um, Moving on, nobody cares. Today we are going to be starting the first organ-specific module, and we're going to kind of start with the bang. Our liver is probably the most complex organ that we're going to be learning about, especially within the abdomen. So there's a lot that goes into this. There are going to be some sections within this PowerPoint that are going to be a little bit confusing to you guys, but just bear with me, get through it, and then try to go back and piece everything together. So the liver itself, the reason why it's so confusing is because we're not just talking about the anatomy and function of the liver. We're talking about a lot of supportive structures that are associated with the liver. So there's a lot of relational anatomy and structural anatomy that we have to be aware of in addition to the basic anatomy and physiology of this particular organ. So there's going to be some challenging slides on this PowerPoint, but again, we'll get through it. So the basic anatomy of the liver, it's our largest soft tissue organ, second to our skin. Typically weighs 3.5 to 4 pounds. It's a pretty chunky organ, usually going to be 15 to 17 centimeters in length. And we'll talk later on in this PowerPoint about how we can measure the liver on ultrasounds. Very important picture that we have to take. Typically, we divide the liver, as we know, into 3 specific lobes. We'll talk all about that. The majority of our liver tissue is going to be located in that right hypochondrium region, with portions of the left lobe extending into the epigastric region, and sometimes extending even further into the left hypochondrium region, depending on how big our patient's anatomy is. Our liver itself is going to be covered by 2 specific things, or 2 specific layers. We have a peritoneal covering, that's going to be our outer covering. It's going to cover all of the liver except for 3 particular areas. The bare area, which is going to be a region of the upper portion of our liver that is in direct contact with our diaphragm, the area where our gallbladder sits, and the area where our IVC communicates with the liver. So fossa is a fancy medical term for area. And then our second layer that's going to cover the entire organ itself without any exceptions is going to be our Gleason's capsule. So if we look at the picture on the bottom right-hand side, we see our liver parenchyma. Parenchyma is going to be the term that we use moving forward to reference any functional tissue. So any organ that produces a function is going to be referenced as parenchyma. So the liver functional tissue, parenchyma, is going to be that kind of brown box at the bottom there. Directly on top of that liver parenchyma is going to be that Gleason's capsule. It's going to cover the entire organ itself. And then another small layer on top of that is going to be our peritoneal covering, which is going to cover the majority of that liver with the exception of those 3 areas. Picture on top is kind of an upward kind of eagle's view looking down onto the liver. We can see that that bare area is not covered by any peritoneum, and that's going to be the area that's in direct contact with our diaphragm. Mentioning really quickly, we're not going to spend any time talking about this, but we have to be aware of what this is. This tends to be a very big registry question. There is a different type of anatomic evaluation of the liver in different parts of the world. A lot of European medicine uses what we call Koynad's segmental anatomy to evaluate the different sections of the liver, whereas we use more lobar anatomy here. The difference with Koynad's is it divides the liver into 8 specific sections depending on the blood supply to those sections. A lot of liver surgeons, even in the US, will use this type of anatomic evaluation because it's a little bit more precise in evaluating the location of something. So you have to be aware that this exists, what the purpose of it is, and how it's a little bit different than the standard lobar anatomic eval. So, oh look, how fun, you can see my previous drawings from all my other recordings. So let me just erase all of that for right now, and then we can start fresh. Bear with me. Okay, so our lobar anatomy, as we know, we have a right lobe, a left lobe, and a caudate lobe. Our right lobe is obviously the largest one, followed by our left lobe, followed by our caudate. Our right lobe is actually 6 times larger than the left lobe, and there are certain structures that we have to be aware of that provide specific divisions between the lobes. So between our right and our left lobe, we're going to have a lot of structures that provide a division, that provide kind of a little bit of a barrier between the two lobes. We have our main lobar fissure. Fissure is really talking about a supportive pathway, right? So imagine like a school, right? You have classrooms, they all empty out into a hallway. So that hallway is going to be more of just kind of a directional pathway, right? It's going to be a space where students can gather, but you're not really doing anything important in the hallway. You're not learning anything in the hallway. You're not doing anything in the hallway other than like moving, right? So it's kind of like a storage for the liver. The main lobar fissure, it's going to provide that structural division and also kind of storage of our gallbladder right in between the right and the left lobe. Our gallbladder is going to be located within that main lobar fissure, so it's going to protect the gallbladder a little bit. We also have our middle hepatic vein, which we're going to talk all about the vascular supply and drainage of the liver as we move forward in this PowerPoint. So we'll definitely come back to this, but it's going to divide the lobes from an upward kind of division, whereas the main lobar fissure is going to divide it from more of the bottom part of the liver moving upward. We also have our falciform ligament. This is going to be an extrahepatic portion of our ligamentum teres, which we will talk about these further. And it's going to extend from the diaphragm down through the anterior part of the liver and attach to the chest wall. So it's more of an outer structural supporting team member. So this picture is really great. Again, I have all my drawings on here from my previous recordings. Oh, this picture is actually right from your textbook. Your textbook is really helpful with this chapter. So please, if any of this stuff is confusing to you, go over to the liver chapter in your textbook. The pictures are really, really helpful, especially the ultrasound pictures that they have in there. So here we have two different pictures kind of showing the main parts of the liver. Picture on the right hand side is going to be a forward view of the liver if we were looking directly at somebody's liver, and the picture on the left hand side is if we were looking from the back side of somebody's liver. From the front of somebody's liver, not really much going on that we need to be aware of. We can obviously see the right lobe and the left lobe. And then we start to see our ligamentum teres and our falciform ligament. So those are kind of the takeaways that we want to be aware of from mainly the anterior part of the liver. Talk about them as we move forward. From the back side of the liver, we can see a little bit more going on, and that's because some of these supportive structures and neighboring structures are going to be located towards the posterior side of the liver and also towards the inferior aspect of the liver. Everything kind of comes and goes through the concave border of the liver, and we'll see that when we learn about what we call the porta hepatis. So on this picture on the left-hand side, everything's going to be flipped because now we're looking from the back side forward. Left lobe is on the opposite side, right lobe, again, on the opposite side. We want to be aware of our, again, ligamentum teres and our falciform ligament. The two kind of go hand in hand with each other. They're different parts of the same sort of structure. And then we're not seeing it labeled here, but our main lobar fissure is going to be the area where these structures are typically going to sit. So we might pop back over to this question, to this slide as we move forward. My Blackboard does not know what to do. It's like, man, we've recorded this how many times now? This PowerPoint's going to be exceptionally long just because I have to delete everything as I go. Oh, this is not my best, guys. Bear with me. Okay, so continuing on with some of our structural divisions here. So we talked about the differences between the right lobe and the left lobe, what divides those, and then what's going to divide that caudate lobe from our left lobe. So we know when we're scanning, when we see that caudate lobe pop into our screen, we know that there's a lot going on in that area. So we're doing typically a sag left lobe of the liver, and we kind of see like this stuff going on here. So we have sag left lobe. We know as we're sweeping towards that patient's right side, we're going to pass the aorta. We're going to see IVC. And then we're going to see this little bulb of caudate lobe tissue kind of pop in to that left lobe. Now, the main thing that makes that tissue kind of pop to our eye is going to be the hyperechoic border that is on top of it, separating it from that left lobe. So that's going to be our ligamentum venosum fissure. So we're going to kind of come back to that term, ligamentum venosum. Hang on to that for a second, but that's going to be a bright echogenic line that's going to separate our left lobe anteriorly from the caudate lobe that's sitting posteriorly. Also in that area, kind of traveling in that region, we're going to see our left portal vein. And then we also know that as we're evaluating the caudate lobe, our IVC is usually going to be posterior to that little caudate bulb area of tissue. And then we also see some other boundaries and margins of that caudate lobe, depending on which side of the caudate lobe we're looking at. So usually when you guys are scanning in this area with sag left lobe, we tend to see this like circular target, like a pattern here. Sometimes it's shadowing, sometimes it's moving. That's going to be our duodenum. So we know that our stomach is going to be nearby, and we know that our small intestine is literally like right there. So sometimes we can see that structure adjacent to our gallbladder. And then we also can kind of see a little extension of that caudate lobe coming in between our IVC and our portal vein. So kind of this little extension that happens here. We would usually see our left portal vein there. So it sits between the left portal vein and the IVC. So again, kind of more registry-like questions here. I was really loving the drawings on my last recording. So, segmental anatomy. So we have our lobes, right, left, caudate. We talked about what divides them from each other, but how do we divide them further within themselves? So everything, actually I could have like kept that drawing because that would have been helpful, but I like to start fresh every time. Everything that we do, like we had said, kind of converges or originates at the concave border of the liver. So this area here where the liver kind of bulges inward a little bit. With that being said, our left lobe typically sits here, right? And then our right lobe sits here. If everything is converging to this concave border, we're going to divide the liver lobes even further, like this, and like this. Right? Because everything's kind of going back to that central point. Now, if we were to categorize these different sections of the left lobe and the right lobe, our left lobe, this would be our medial left lobe. This would be our lateral left lobe. Our right lobe is not going to be medial and lateral. Instead, it's going to be anterior and posterior. Okay, so that's one of those nuances that you have to be aware of in terms of the difference of how we segment the right lobe and the left lobe. So let that kind of piece together a little bit. Now, these separations between the medial and lateral left lobe and the anterior and posterior right lobe are going to be done by what we call intersegmental fissures. So within the right lobe, we're getting anterior and posterior segments by the right intersegmental fissure. And then in the left lobe, we're getting medial and lateral segments by the left intersegmental fissure. Now, in the areas of these fissures, right, we said these fissures are kind of just like empty hallways, like they don't really serve a purpose in terms of function other than support, right? They're areas, they're kind of directional pathways that can be utilized. So within these intersegmental fissures, they're going to contain the hepatic vein and the portal vein for that lobe. So in the right lobe, we're going to see the right hepatic vein and the right portal vein occurring at that fissure. And then in the left lobe, we're going to see the left hepatic vein and the left portal vein occurring at that fissure. Also in that region for the left lobe, we're going to see that ligamentum teres and therefore the falciform ligament externally. So let's talk about those ligaments a little bit more here. The first one that we've already talked about, Gleason's capsule, although it's a covering, it's a protective tissue layer around the entire liver itself, it is still considered a ligament. It's made up of those connective structural cells. So it is a type of ligament. It, like we said, covers the entire liver itself, and it's actually going to have areas that are really, really thick near the IVC and the porta hepatis. Again, we'll come back to porta hepatis. Our ligamentum teres, also known as our round ligament, sometimes we don't really refer to it as the round ligament, but you have to know that for the registry. And sometimes you'll see pictures and diagrams while you're studying that will reference the ligamentum teres as the round ligament. So just know that if you see a picture that says round ligament, it's the same thing. What this is a remnant of our fetal circulation. Now we're going to have two ligaments, our ligamentum venosum, which we'll talk about on our next slide. Both of these are going to be closed off pathways that we were using for fetal circulation when we were in the womb, when we were going through embryology. When we're born, we don't need these vessels anymore. So these vessels close after birth. It doesn't mean they disappear. They just close. So now when we were a fetus, we called it, our umbilical vein, but now when it closed and we're an adult, we term it the ligamentum teres. This is going to have a close communication with our left portal vein. So we're still going to be getting portal vein blood supply in that vessel, but there's going to be like a distal extension to it that is just closed off. So it's just like the closed off portion of the hallway. It's still there, but the lights are off. No one's walking down that hallway to get to class. It's closed. In certain cases of pathology or diseases or certain conditions, that hallway, that pathway, that ligamentum teres can reopen and to allow blood supply to travel through it from that left portal vein. It can reopen. It can what we call recanalize, and we also call that a patent umbilical vein. Do we want to see that happen? No, because it's saying that something else is happening in that patient's body, but it can happen. Okay, so from here on out, we're going to be referencing it as a normal, healthy adult human who does not have any kind of liver condition that is going to stay closed. Okay, so that's going to be now our ligamentum teres. It's going to provide a division between the medial and lateral segments of our left lobe, and we can actually see this on ultrasound when we're doing transverse left lobe, kind of sweeping superior and inferior. We see it as that echogenic little triangle that has that little area of shadowing behind it. So this is something that we can actually see in most patients. Continuing on with our ligaments here, we have our ligamentum venosum, which is going to be similar to the ligamentum teres in the sense that it was something that we used when we were a fetus that we no longer need anymore. So it kind of provides more of a structural support when we're a normal, healthy adult. Now, our falciform ligament, let's talk about that first. That's going to be, this slide should say extrahepatic. That's going to be the extrahepatic extension of the ligamentum teres. So we're going to see on the next slide, the ligamentum teres kind of enters into the region of the liver, kind of goes more into that liver tissue itself, but the falciform ligament kind of stays as like a little fold that stays outward, outside of that liver tissue. So we'll see it in a second. We don't see this on ultrasound, only if we happen to have a patient that has ascites. Ascites, you can Google it. It is when we have an excess accumulation of fluid in a patient's abdominal cavity. And what happens with that is all of this fluid builds up, builds up, builds up. It doesn't really have anywhere to go. So what it does is it starts to push the organs away, away, away from the abdominal wall. So with that, we kind of see this falciform ligament stretching, 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 because it's trying to connect the liver still to the abdominal wall. And now we see it all surrounded by fluid. So that's the only time we see this falciform ligament is when we have ascites, we have fluid buildup that's pushing that liver further away from the abdominal wall. Now, our ligamentum venosum, like we said, very similar in sense to the ligamentum teres. It was a pathway that we used for fetal circulation that we no longer need as a born human being. What this is going to separate the left lobe and the caudate lobe, and it's going to have a little bit of a communication with the ligamentum teres at that concave border of the liver. So where our portal veins kind of start, we're going to see a little bit of a communication between that ligamentum teres and the ligamentum venosum. But the ligamentum venosum is going to be a little bit less important, a little bit smaller. We don't really see it on ultrasound, and it doesn't really have the opportunity to open up in the presence of disease. So the two most important ligaments are going to be the ligamentum teres and therefore the falciform ligament, because the two of them are pretty much connected. So let's see what those look like. I'm going to keep these drawings on here. So ligamentum teres, we can see kind of entering into the liver here. It's going to kind of go inward underneath that surface a little bit, but as you can see, staying out on top of that anterior border is going to be this falciform ligament. It's kind of like this little flap that hangs off, and it's going to go to attach to the anterior abdominal wall. That's what we're going to be able to see when a patient has ascites. So connecting that anterior liver surface to the abdominal wall. The intrahepatic portion, the portion that's going to be within that liver tissue, is going to be the ligamentum teres. Extrahepatic portion is going to sit on the outside, connecting the anterior surface of the liver to the anterior abdominal wall. And then our ligamentum venosum would have a communication with the ligamentum teres right in this region here on the back posterior side of the liver, if we had a different view of this. The ultrasound images on page 222 in your textbook are really, really helpful to see, especially what that ligamentum teres looks like when we're scanning. Next, we have our fissures. So we have our, like we said, these were kind of our pathways, don't really serve much of a purpose other than structural support and opportunities for pathways if necessary. Main lobar fissure, most important one. We know that that's going to divide our right and our left lobes from each other. We can see this on ultrasound. In SAG, it's going to be a thin echogenic line that we can see extending from the region of where our gallbladder is to the area of our right portal vein. Again, bear with me, we're almost at the vascular supply. In transverse, we can also still see it extending from the gallbladder to the IVC. And then a little bit less, not less important, but a little less obvious, we can't really see them on ultrasound, are going to be those right and left intersegmental fissures, like we talked about in terms of dividing the left lobe into medial and lateral segments and the right lobe into anterior and posterior segments. I misspoke on slide, I believe I did. What slide was that? Hold, please. This one. The left lobe should be flipped. Lateral, sorry, and medial. Sorry. I knew something seemed wrong. So our right and left intersegmental fissures are going to divide those lobes into those further segments. So again, just kind of recapping fissures, putting those all together. Okay, moving into our vascular supply and drainage. The vascular supply to the liver is very unique. Typically in our body, arteries supply blood, veins drain them. That's still kind of the case with the liver, but we actually have an artery and a vein that are both going to be supplying the liver. And then we also have veins that are still draining the liver. So the supply to the liver is very, very important, and it's complex. Drainage, a little bit less complex. Our liver is going to receive the majority of its blood supply by the portal vein, which is a little bit different than what we're probably used to. The other supply to the liver, a little bit less supply to the liver, is going to be through the hepatic artery. Now, the veins that are going to drain the liver are going to be the hepatic veins. We have 3 of them. We have a right, a middle, and a left. All 3 of those are going to drain into the IVC, which is going to bring everything back to the heart. We're going to talk about these different segments a little bit further, but just kind of piecing these together because I like these pictures on here. Picture on the left-hand side. We said the majority of our supply is coming from the portal vein. The portal vein is made up of our SMV, which is our superior mesenteric vein. This comes from our bowels, and our splenic vein, which comes from our spleen. So we have our SMV and our splenic vein. Those two join together to form our main portal vein, which is going to go into the liver. Once it's in the liver, it's going to branch off into a left portal vein, which is obviously going to go to the left lobe, or a right portal vein, which is obviously going to go to the right. Okay. Now, the hepatic artery, if we look at the picture on the right-hand side, so the rest of the blood flow to the liver is going to come from basically the aorta. It's going to come from an artery. So we have our aorta, we have our, my little drawing thing is being very slow. We have our celiac axis here, which is going to be the branch off our aorta. Our celiac axis has a bunch of branches that come off it, but the one that we care about right now is going to be our common hepatic artery. Our common hepatic artery is going to have some branches that also come off it, but the main direction of this common hepatic artery is going to be into that liver. And then from there, it will split into left hepatic artery or right hepatic artery. Now, the drainage of the liver, pretty straightforward. We said we have a left, a middle, and a right hepatic vein. All of those smaller veins, see like the smaller vein, all of these smaller veins here, they're all going to converge, meaning they all join together to form three larger ones, the left, the middle, and the right. The left, the middle, and the right all drain into the IVC. Sometimes, usually, we're going to see the middle and the left join together prior to emptying into the IVC, and then the right kind of enters in on its own. So sometimes we see a little bit of like a joint connection between the middle and the left prior to them emptying into the IVC. But we'll talk about that again in a second. So all of those will drain into the IVC and back to the heart. So it's a very basic overview of the supply and the drainage. Supply is always going to be a little bit more complicated. Porta hepatis. Okay, so porta hepatis is literally just saying the area, the port of the liver, right? Hepatic, hepatis, it's all talking about liver. Porta is literally saying it's a port. So this is going to be the region of the liver where either everything enters or everything exits, with the exception of our hepatic veins. Our hepatic veins exit the liver, but they do not exit the liver at the porta hepatis. Little notes here, guys. So this is technically considered a fissure, and it's where our main portal vein and our hepatic artery are going to enter into the liver, right? We just talked about those two structures that supply. And then we have a common bile duct from the gallbladder that's going to exit the liver at the same area. So at the porta hepatis, we're looking at these three structures. We're looking at the main portal vein, we're looking at the hepatic artery, and we're looking at the common bile duct. Hepatic artery and main portal vein are entering, common bile duct is exiting, okay? We typically reference everything in the liver in this sort of like tripod, and we call that the portal triad. So usually throughout anywhere in the liver, whether it's the big artery and big vein or it's some of those smaller arteries and veins out in that parenchyma, we usually see these three type of structures traveling together. We usually will see a hepatic artery, a portal vein, and a bile duct traveling nearby. And this is not just within the porta hepatis. This is anywhere within the liver. We see these three structures kind of traveling side by side with each other. The porta hepatis itself, these three main structures at the porta hepatis, the main portal vein, the main hepatic artery, and the main common bile duct, we reference that as the Mickey Mouse sign in transverse. So that picture on the right-hand side, we can kind of see a little Mickey Mouse little appearance there. That's going to indicate our portal vein, the big one, our hepatic artery, one of the smaller ones, and our common bile duct, and an additional smaller one. Now, how do you tell the difference between the hepatic artery and the common bile duct? You put color Doppler on. The hepatic artery was going to light up with color flow. The common bile duct is not, because it's not a blood vessel. It's a bile duct. So that's pretty straightforward stuff there. Now, talking a little bit more specifically about the hepatic arteries and the portal veins, and then also the hepatic veins, we're going to kind of roll through these individually a little bit more. Like we said, hepatic arteries are going to bring oxygen-rich blood into the liver, although they are not the main supply to the liver. So from our aorta, we are going to have a celiac axis. That's going to be the first branch off of our aorta in our abdomen. Our celiac axis is going to branch off into a couple different things, but right now we care about our common hepatic artery. Our common hepatic artery is going to have a bunch of branches that come off it as well, but it's going to divide into right and left branches once it enters into the liver. Important reminder, there's no such thing as portal arteries, okay? I don't know. I don't know if you have to get like some kind of stamp to put that somewhere. No such thing as portal arteries. Hepatic arteries, hepatic veins, portal veins, okay? No portal arteries. Did I make that clear? Okay, so here is that kind of zoomed in view of everything that's going on in terms of the common hepatic artery branching off the aorta and heading into the liver. So here we have our aorta, literally looks like a hot dog. Our first branch in the abdominal portion of the aorta is going to be our celiac access. In this case, it's calling it the celiac trunk. We said there's a bunch of branches that are going to come off that celiac trunk, which we'll learn about in a few weeks. We don't care about them right now. And then as that common hepatic artery travels to that liver, a bunch of branches are going to come off it. Again, we don't care about those right now. What we do care about is how that common hepatic artery gets to our liver. So here's our porta hepatis. Boop, enters right in. Once it does, it's going to split into our left hepatic artery and our right hepatic artery. Probably shouldn't have used orange on top of that, like salmon color, but pretty straightforward here. And just make a little note saying that we are going to come back to what these branches are and the relationship with that aorta a little bit further a few weeks from now. Here's what this will look like on ultrasound. We have to put color Doppler on, and then we also put pulse wave Doppler on to evaluate the blood flow of the hepatic artery. This is called our spectral window, where we can actually see what that pulse waveform looks like, and we can actually see what is that artery doing in that section when we sample it. So it's giving us a nice arterial waveform. Portal veins also going to be the main supply to the liver. It's going to bring nutrient-rich blood from the intestines to the liver. Like we said, the portal vein is comprised of the superior mesenteric vein from the intestines and the splenic vein from the spleen. Those two vessels join together to form that main portal vein. And then from there, it will branch off further. That connection between the SMV and the splenic vein is what we call the portal splenic confluence. The two of them are kind of converging together. At the porta hepatis, that main portal vein is going to divide into right and left portal veins, respectively going to the right and left lobes. The left portal vein is going to travel vertically into the left lobe, and then the right portal vein is going to kind of travel transversely into that right lobe. And then from there, the right and left portal veins branch even further, but we don't have to really get too involved in that process. Like we said previously, hepatic arteries, portal veins, and bile ducts all tend to travel together. Usually, the bile duct and the portal vein travel parallel to each other, and the artery travels perpendicular between those two. So because the bile ducts and the portal vein travel parallel to each other, on ultrasound, we refer to this as the parallel channel sign, or double barrel sign, or shotgun sign. So what does that mean? So that means here we have our portal vein traveling, and here we have a bile duct traveling. And then usually perpendicular to the two, we'll have the hepatic artery. So because the portal vein and the bile duct are parallel, it gives us that shotgun sign, right? It's like, I don't really know guns or anything, but like it has like the two chambers, like the two parallel tubes. I like to just reference it as the parallel channel sign because it's literally telling you exactly what it's going to look like. So here we have our diagram, our bigger picture of our portal system. Like we said, the main portal vein is going to be made up of the splenic vein that comes from the spleen, which we're not really seeing in this picture here, but our spleen would be in this region and would be coming this way. Our SMV, our superior mesenteric vein, is going to be this area here where all the veins from our intestines are coming together. joining with our splenic vein to form our portal vein, going up into our liver, left portal vein, right portal vein. A bunch of branches coming off from those respective sections. So here's what this looks like on ultrasound. This is going to be the picture on the left-hand side, the picture at our porta hepatis, so our main portal vein here. And then we can kind of see the left portal vein traveling vertically, and our right portal vein, it's going to be this segment here before it splits, kind of traveling horizontally. And then we can see those further branches. Now the reason that this branch of the portal vein and this branch of the right portal vein are representing two different colors, it's not because they're behaving in two different fashions. It's because, is this blood flow traveling towards the transducer? Yes. Is this blood flow now traveling away from the transducer? Yes. So it's still traveling out into that right lobe tissue, but the pathway in which it's traveling is opposite in reference to the transducer. So it's not traveling in two different directions. It's just either traveling to us in terms of the transducer or away from us. So sometimes color with color Doppler can be a little bit tricky. And then here we can see our common bile duct also entering to our porta hepatis at that region. We see our main portal vein, common bile duct, and then right here we see our hepatic artery. So it's kind of showing us that nice parallel channel sign. Hepatic veins, these are going to drain the liver and communicate directly with the IVC to go right back to the heart. We have three of them, three major ones, the middle, the right, and the left. We'd said previously that our middle and our left sometimes join together prior to emptying into the IVC, but regardless, all three of them empty into the IVC to drain the liver completely. The middle hepatic vein, we had mentioned previously, is going to be located within the main lobar fissure. It's also going to help to divide the liver into those right and left lobes. Our right hepatic vein is going to be in the right intersegmental fissure, like we had previously said, helping to divide that right lobe into anterior and posterior segments. And then the left hepatic vein is located within the left intersegmental fissure, again, dividing the left lobe into medial and lateral segments, all communicating right with that IVC. Now we said most structures, most things enter and exit the liver at the porta hepatis with the exception of the hepatic veins. So the hepatic veins drain towards the top of the liver. Everything else happens down here, right? So the hepatic veins are going to be different from that. So if we're trying to find them, we always want to be looking more upward towards the superior border of that liver. So here we can see our left hepatic vein, our right hepatic vein, and then the middle hepatic vein here, draining with that left, and then all three go into our IVC, which will dump right back into our heart. Here's what all three of those look like. Very pretty. So in this image, it looks like everything is entering and exiting at the porta hepatis, and I can see why it appears like that, but we don't know how steeply superior they're angled in this picture. So if they are angling their transducer really far up under those patient ribs to the point where they're seeing the dome of the liver, that's where we're going to get our hepatics draining. Okay. Now, if we were to come down more inferiorly, that's when we're going to start to get to that inferior concave border where the porta hepatis is. So you can't just look at a picture and be like, oh, well, it looks like they're in the same area. You don't know what approach that tech is using to obtain those images. So a little chart to help you differentiate some of the characteristics between the hepatic and the portal veins. You can use this to help you study. We're not really going to go through this. It's pretty straightforward. It's just kind of accumulating everything that we've mentioned about these vessels. So physiology of the liver, what is the main purpose, main function of this liver? It's usually going to be referenced as a metabolic organ. So the primary functions are going to be to produce bile and help secrete bile with that close relationship to the biliary system, excrete hormones and drugs filtering through our body, metabolism of fats, proteins and carbs, enzyme activation, storage of glycogen, vitamins, minerals, synthesis of plasma proteins, albumin and clotting factors that are necessary for our cardiovascular health, blood detox and purification, and the production production of Kupffer cells, which are going to be functional cells that help us to fight against invading organisms. So helping with our immune response as well. So pretty hefty, important tasks that this organ is responsible for. So how do we evaluate it, right? All of that said and done, how do we evaluate it? What are we looking for? What are the most important things? You want to be able to assess the size of it, but further than that, you want to be able to make sure that you are evaluating every piece of tissue. So we are looking at all of that parenchyma, or evaluating the echogenicity of that parenchyma, the contour of it, right? What does the border look like? What does the tissue look like? Is it smooth, coarse, lobulated? Is it more hyperechoic than it should be? Is it really small and hypoechoic? How's the vascularity to it? Is it super vascular, what we call hypervascular, or is it lacking vascularity? What does that blood supply look like, right? Do we get appropriate blood flow in the portal vein or the hepatic artery? What do our hepatic veins look like? Are there clots in any of those vessels? We also look at our biliary tree. We know that our gallbladder sits within that main lobar fissure, so we have to look at that and make sure that's okay. And then we're looking for masses and fluid collections. So these three pictures here are showing the subtle differences between what can be considered abnormal. None of these images are considered a normal liver picture. Picture on the top left-hand side, if we look at that texture, it's not nice and smooth, right? It's not nice and homogeneous. We're getting kind of little areas or waves where it kind of looks a little bit vague and blurry. So that's going to indicate a coarse texture. Picture on the bottom left-hand side, still getting a coarse texture. It's not nice and homogeneous, but also look at the surface of this structure, right? Here we have kind of like this wavy border. That's going to indicate some sort of cirrhotic disease. We'll learn all about cirrhosis. And the picture on the right-hand side, you're probably thinking like, well, that could be a normal liver. Maybe I just need to fix my posterior TGC. True, but there's other things that's kind of sticking out and showing to you that this is not a normal liver. Look at these areas of shadowing that we're getting over here. This is going to indicate what we call fatty liver. That's kind of the general term that we give it, also known as fatty infiltration or hepatic steatosis. That's when our liver has way too many fatty cells in it that it can't filter out, and that is a dietary issue. So if you have a diet that is high in fatty products or carbohydrates, it gets stored as glycogen and fatty tissue in our liver. Because our liver is now holding on to these excess cells that are made up of fat, the fat is soft, so it's going to make it appear hyperechoic, but it's going to absorb a lot of that sound wave. So we're going to get a lot of shadowing and loss of penetration in those posterior field of view. So this tissue over here looks kind of bright, very hyperechoic, and then very drastic. This tissue over here looks kind of bright, very hyperechoic, and then very drastically we lose a lot of penetration, and we're getting a lot of attenuation that's happened, a lot of sound absorption that's happened in that posterior field of view. That's a classic appearance of fatty infiltration or fatty liver. Patient prep. So we need them to be NPO, nothing by mouth, for 6 to 8 hours to minimize the amount of bowel gas that they have and to also prevent any biliary contraction. Water, if a patient has to take medications, is completely acceptable. We never refuse water for a patient or meds for a patient. Limitations, physical limitations with this, of course, all of those liver conditions are going to be harder for us to evaluate. So fatty liver is harder for us to evaluate the posterior part of that liver tissue because of the extensive attenuation that occurs. Other liver metabolic conditions can produce the same sort of effects. But obesity is going to be the largest limitation that we have, and that's just because the more fatty tissue that we have between the transducer and the organ itself, the worse our penetration is going to be, the increased depth we have to use, and just overall we're not getting great detailed pictures. So this picture with the 2 ultrasounds is really showing that the more depth we have to evaluate through before we get to the structure that we want, the worse our picture quality is. So picture on the top is showing a fetal head at the depth of 7.6 centimeters, kind of vague, kind of blurry, and then at a depth of 3.7 centimeters, much more clear cut. we can see detail and resolution with that picture. So it's just the nature of our ultrasound physics. We just can't see further into the body. Also, anyone who has a barrel chest, this is an anatomic deformity that a lot of men have. It's when their chest is just very round, wide, and short, and it makes it almost impossible for us to evaluate all of their liver tissue because it sits so high up in their sternum. How do we optimize our liver visualization? So what are some things that are within our control that we can try to implement to help us? So we need to be altering our patient approach. We're not just putting our transducer down in one window and calling it a day. We're going from anterior approach to coronal. We're going under the ribs. We're going in between the ribs. We're going to be altering our patient position. So we're having them turn on their side for an oblique position, or we're having them turn completely on their side for a decube position. We're altering our gain and our TGC settings. We're making sure that our picture is uniform in brightness and changing that in the appropriate way. We're also adjusting our frequency. So as our patient body habitus increases, we also have to decrease frequency for increased habitus. We have to decrease that frequency to allow for more penetration. As we're adjusting our frequency, we have to be aware that we should also be adjusting our depth and our focus. And then also tips, scanning tips, things that you can have your patient do. Have them take in those big breaths. That's one thing that students do not do. You do not ask your partner to take in a big breath. You're afraid to ask a patient to take in a big breath. You will never get the picture that you need if you don't. Also, a Valsalva technique. It's where we have the patient sort of squeeze their abdominal muscles like they're doing a sit-up. And it kind of puts pressure on some of their abdominal structures to help them pop out or pop closer to our transducer. You can also do the pot belly technique, which is very similar. You have them blow their belly out like they're pregnant or have pot belly, and that can sometimes help move organs into our field of view or help move gas pockets out of our way. Scanning techniques. Make sure you are beginning with an entire full sweep of the liver in sag and transverse. In lab, it's a little bit different. We can kind of take pictures as we go, but when you're scanning real patients, you need to get a lay of the land. You need to make sure you're seeing the bigger picture before you go and you take your dedicated sagittal and transverse pictures. Make sure you're having your patient take in those deep breaths and holding it. We're scanning in sagittal with the subcostal approach, going from medial and lateral left lobe. Same thing with the right lobe, but we may have to go intercostally for that right lobe with the coronal approach. And transverse, same thing. We're sticking with that anterior subcostal approach, scanning superior to inferior left lobe, and same thing with that right lobe, having to pop back to coronal using intercostal. Make sure you're adjusting your patient as necessary to be using the best possible imaging window. Again, there's no rush with this, right? We're practicing, we're going slow, we're taking our time, we're trying new things. What are we looking for? We're looking for the internal architecture. So the normal internal architecture of the liver should be homogeneous. We're looking for the texture. Is it smooth or is it coarse? Obviously, our liver should be nice and smooth. The size in sagittal, we need to be measuring from the diaphragm down to the inferior border of the liver, taken at the midclavicular line. Should be about 15 to 17 centimeters. Don't necessarily care too much about an AP diameter, but your textbook or your registry may ask that. Echogenicity, we're looking for in relationship to the kidney. We want to see it slightly hyperechoic to the renal cortex. Again, we don't want to see it very hyperechoic because that could indicate fatty liver. So echogenicity for us, we want to see it moderately echogenic throughout. Again, homogeneous, medium shade of gray, slightly hyperechoic to that renal cortex. What are we documenting? This is our pretty basic protocol. We'll go over this more so in lab, but you can make a little note of this for lab. And then we can make sure we obtain these pictures while we're scanning. These are not things that you necessarily have to include in your images, but these are structures that are going to help you identify where you are. So don't be so hung up on trying to take your transverse left lobe and you can't really see your ligamentum teres that well. I care about the quality of the liver in your pictures rather than the quality of these surrounding structures in your pictures. These are just kind of accessories to help you. So here we have kind of our progression of our SAG pictures, SAG left lobe, like we're reading a story, starting on top from left to right. These are our typical, Sag, regular patient. We're sweeping here, coming in more towards the patient's right side. We're seeing their aorta in that middle picture. Sweeping even more towards that patient's right side, we're seeing that left hepatic vein draining into our IVC. We also see our caudate lobe with our ligamentum venosum here. So our sag left lobe on top and then sag right lobe on the bottom. If we were to continue sweeping towards that right lobe, we want to go all the way to the diaphragm. So we see this hyperechoic border in that superior aspect in sag. As we come back down, we're going to start to see our main portal vein. We'll see our gallbladder kind of in that porta hepatis as well. And as we continue sweeping medially, we'll see our kidney pop into our field of view. And then transverse, same thing, transverse left lobe on top, transverse right lobe on the bottom. Transverse left, we're seeing this triangular area of tissue. And then we're going to kind of continue to sweep down. We're going to see our portal vein here. This picture could be taken with a little bit more anatomy going this way. And then as we come down even more inferiorly, we're going to see that ligamentum teres, that echogenic triangle between our left and our right lobe with a little bit of shadowing. And then our transverse right lobe all the way up at the top of our liver, we're going to see our hepatic veins draining out. As we come down, we'll be more so in that transverse view of our porta hepatis, again with our transverse gallbladder. And coming down even more inferiorly, we'll see our kidney pop into our field of view. And then lastly, there are some normal anatomic variants that we have to be aware of. So some people just happen to develop these when they're born. It's not considered a pathology. These are considered normal. So Riedl's lobe, that's going to be a variant of the right lobe that extends really, really far down. It's kind of like this tongue-like extension, and it's more common in women. If we look at this CAT scan on the top here, we can see this right lobe that extends like really far down into the patient's pelvis, almost touching their pelvic bone here. So obviously, most normal patients, it's going to kind of be like that. With that, you want to make sure that you're also evaluating all of that tissue so that there's not like a mass hanging out in that region. Then we have a papillary process. This is going to be kind of in the area of our caudate lobe. It can mimic a lymph node in that region. So sometimes they'll go for follow-up imaging just to prove that it's a papillary process. It's going to be very similar in echogenicity to the liver. It can be also confused with the caudate lobe. So you want to make sure you're identifying the caudate lobe separately from that. And that would be this area here. And then here's our papillary process. So these would probably get a follow-up. A Riedl's lobe, probably not so much. So a lot of information on here. Again, your textbook is very helpful with this, but please, if you guys are having any questions or doubts about this, or you're not sure, or maybe you think you get it, but you're not like 100% confident that you get it, please make sure you're asking clarification with me before we move forward.